Medicare Advantage Efficiencies. Although involved in a government program, Advantage insurers are private entities with private incentives that have to compete in a market. One of the points to creating Advantage in the first place was to take advantage of these efficiencies. Despite the persistent overpayment problem, maybe Advantage is still a good program due to these efficiencies. When looking at spending by the beneficiary and the insurer, meaning not capitated payments given to Advantage plans by the government, but the actual spending of the insurance organization and the enrollee, studies often find that those in Advantage have less medical spending by them and their insurer than those in traditional. Unfortunately, these studies often don't tell us much because Advantage enrollees are healthier in the first place. Some of this lower medical spending could be caused by Advantage efficiencies, or close to none of it could be. Also, if spending is lower because people are discouraged from using legitimate medical care, then that lower spending isn't a good thing. Many studies done by or hired by insurance companies claim that Advantage costs less than traditional, but these only use risk scores to control for selection and do not determine how much the same person would have cost if they were in traditional instead of Advantage, like MedPAC does. We already know that risk scores don't fully account for differences in selection. Industry studies have tried reducing traditional costs by 5% to crudely account for coding and selection differences, but those differences are much greater than 5%. At least some studies measure resource use as insurance reimbursement to the provider, but sometimes resources are used and the plan refuses to reimburse. Advantage refuses more often than traditional, so this will falsely exaggerate the resource use of traditional patients compared to Advantage because a higher percentage of healthcare resources used by Advantage enrollees were not accounted for due to the provider not being reimbursed by the insurer. Despite the problems, I think the variety of studies make clear that Advantage enrollees do use less medical resources than traditional enrollees due to utilizing medical services less and using cheaper options when they do. Furthermore, while much of the difference between use is due to selection effects, studies have shown that some of the lower resource use is caused by controls and limits insurers use to limit medical care. At least from a spending on medical care perspective, this means Advantage has shown some benefits from its efficiencies. The techniques used by Advantage plans can lower medical spending. Traditional Medicare does sometimes pay for care that is wasteful. For example, traditional Medicare pays billions a year for the drug aflibercept, when evidence shows the less expensive bevacizumab works just as well. According to one recent study, Advantage plans spend 9% less on medical services than traditional for comparable enrollees. According to another study, within 2 years of joining traditional Medicare from under 65 commercial insurance, people have 35% more costs compared to the 2 years before their enrollment when they were in commercial insurance. This increase for Advantage enrollees was about 11%. The reduced utilization was concentrated in acute care utilization like hospitalizations and emergency department visits. This is purported as powerful evidence showing how efficient Medicare Advantage is. This study should be taken with a grain of salt. The study only looks at people who stayed with their initial Medicare enrollment type for at least 2 years. We know that those who switch from Advantage to traditional on average spend more, and that those who switch from traditional to Advantage on average spend less. This study does not include these people, so the study is pre-selecting a group of Advantage people who on average need to spend less, and pre-selecting a group of traditional people who need to spend more. It tries to only compare similar people, but we can't really determine how much someone needs to spend and which people's diagnoses will lead to involved medical problems. Another problem with the study is that the spike in medical use could be from people delaying care until they get their more generous Medicare plan. People who are delaying more care are more likely to join traditional over Advantage in the first place. The authors claim that the spending isn't simply delayed care because the increased medical spending is sustained. This doesn't solve the problem for 2 reasons. A. Some segment of delayers are just generally sicker and will have sustained higher costs for years, or even the rest of their lives, unless it is something that they can be cured of and that didn't impact other areas of their health. B. The sustained period that the authors use to argue that this isn't delayed care is only a period of 2 years. If someone needs large medical interventions, it could take more than 2 years to get all of that done. For example, if someone needs surgery, it takes time to prep, then have the surgery, and then recover. People can prioritize their worst health issues, then get their other ones seen to over some number of years. Additional problems with this study: it is not peer-reviewed, gives a dearth of information compared to an academically published study, and is done by a company whose customers are health insurance companies. So, the company financially benefits from Medicare Advantage. Reviewing the scientific literature, in general, studies have found that compared to traditional enrollees, Advantage enrollees use less emergency department visits, less ambulatory care, less hospital stays, less home-based medical care, cheaper primary care physicians, less outpatient surgical care, less low-value services, less skilled nursing facilities, less specialists, less inpatient operations, and less utilization. One study looked at Advantage enrollees who left Advantage for traditional after their private insurer left the market, focusing on cases where there were no other Advantage providers in the county. This way, the change to traditional may not have been related to the individual's health, although counties with less healthy populations would be more likely to not have an available Advantage insurer. So we may be looking at a more expensive population in the first place. Using hospital discharge data linked to Medicare enrollment data, they found that those forced to switch to traditional had an increase of 0.11 hospital admissions per capita, a 60% increase over the average 0.18 admissions. They also had a 48% increase in days spent in the hospital, 33% more procedures, and 53% more hospital charges. I'm not sure if they accounted for the normal year-to-year increase as someone ages, or that these populations may have been more costly than normal. The increased utilization did not fade with time, so this doesn't appear to have been pent-up demand, and other county trends did not seem to explain the changes either. The authors concluded that this was caused by the enrollees previously having longer distances to in-network hospitals and restrictions on elective and non-urgent hospitalizations while they were in Advantage. They did not find evidence that this was caused by cost-sharing differences. No study perfectly gets rid of the selection issue, but the sum of the different studies is enough to conclude that Advantage does successfully reduce medical spending compared to traditional. Medicare Advantage prices. Advantage primarily spends less due to lower utilization in the types of services used, rather than lower prices for the same services. However, Advantage does tend to pay a little less for the same services compared to traditional. Advantage plans also have lower reimbursement rates, meaning a lower percentage of provided care is actually paid for by the insurer. These are often caused by denials and prior authorizations that cause longer stays but no additional reimbursement. This includes delays in transferring patients to skilled nursing facilities caused by waiting for prior authorization requests. After accounting for differences in case mix, geographic areas, and hospital networks, a study found that Medicare Advantage paid 5.6% less for hospital services than traditional Medicare. Rates paid by under 65 commercial plans were higher than both Advantage and traditional. A 2023 study looked at prices for the same insurer from the same provider, but comparing Advantage plans to commercial health insurance plans. Hospital prices for commercial insurance were 2 to 3 times higher than Advantage prices. A 2015 study spoke to hospital and insurance executives about the difference in Advantage and commercial prices and found that, first, out-of-network Advantage providers get traditional Medicare prices, so even without joining the network, hospitals must take Medicare prices, giving insurers bargaining leverage because there is no provider threat of sky-high prices for enrollees if the hospital is out-of-network. This is why Advantage prices tend to be close to traditional prices. Second, Advantage plans have to compete with traditional Medicare, and if Advantage plans have high prices from providers compared to traditional, Advantage premiums would be too high to compete. Third, hospitals may actually be considering that the insurers also contract with them for commercial insurance and therefore take the hit on Advantage prices while making up for it with higher commercial prices. However, it's possible that Advantage plans see every dollar spent in Advantage as a lost dollar. While for commercial plans, about 2/3 of the market is funded by employers, so employers are paying some of the claims, and it may be hard for employers to fully self-fund because they don't have enough market power to negotiate with hospitals. Looking at claims from 2007 to 2012, a study found that advantage payments to doctors were more closely tied to traditional Medicare rates than to commercial prices. Advantage plans tend to pay less than traditional. While Advantage will use commercial prices where traditional is overpaying, generally, Advantage prices are close to traditional prices. Advantage depends on traditional and legislation rather than simply free market skill. Under 65 commercial plans pay providers much higher prices because Advantage can rely on legislation and Medicare's government negotiated prices. The Medicare law does not let providers bill patients more than the rate set by traditional Medicare. Providers can't charge more than the traditional Medicare rate, whether they are in-network or out-of-network, unless they reject Medicare altogether. This gives Advantage plans huge bargaining leverage. If Advantage plans had to pay commercial rates, they would not be able to compete with traditional Medicare. Advantage plans have another advantage when negotiating with providers compared to other private insurance plans. If Advantage plans cannot successfully negotiate with providers, their plans will fail and their enrollees will go to traditional Medicare, where the provider will pay traditional Medicare prices anyways. This means traditional Medicare acts as a backstop to provider prices and helps Advantage plans negotiate. It also means that without traditional Medicare plans, Advantage plans may be paying providers more and therefore be more expensive. Additionally, it means Advantage can't cleanly claim to be the superior system when it relies on traditional Medicare and Medicare rules to keep medical costs down. Administration costs. By one accounting, per person, the U.S. spends from $1,055 to $2,497 on healthcare administration costs. By comparison, Germany spends $306. The U.S. spends more than other advanced countries on healthcare administration costs. Administrative costs make up 15 to 30% of healthcare spending, and half of administrative spending may be wasteful. Estimates put traditional Medicare administrative costs at 2 to 3% of expenditures. The estimates for Advantage are from 11 to 15%. By one estimate, Medicare Advantage bureaucracy takes up 14% of Advantage revenues compared to 2% for traditional Medicare. Private insurers spend money on marketing, underwriting, reviewing the legitimacy of claims, and profits. Some of traditional's administrative costs are borne by other agencies and are not recorded as basic traditional costs. Legislators, staff, and others work on Medicare, but parts of their salaries are not included. This also includes building and marketing costs, the collection of premiums and taxes, and accounting costs that include auditing and dealing with fraud. So, some of the administration difference may be exaggerated. That said, ideological critics of government seem to exaggerate the extent that traditional costs are not included. Some of Advantage's administrative expenses may make private insurance more efficient. According to a 2018 study, Advantage plans were more efficient at reducing health expenditures but had higher administrative costs than traditional. Traditional Medicare does less to manage benefits and therefore spending. So, paying more on administrative costs may help reduce spending overall. This comes from preventing or narrowing care, but also preventing erroneous payments. So, traditional saves money on administrative costs, but pays more on fraud, waste, and potentially unnecessary care. Administrative costs also come from quality improvement activities like following certain patients to see which interventions work best, or recording the rate of heart attacks after the taking of certain drugs. A 2023 study looked at a Medicare program that searched for unnecessary spending, estimated that for each dollar Medicare spent monitoring, it created $24 to $29 in government savings. The majority of this was from preventing future care. The study did not find that the patient's health was harmed. This suggests that some of the administrative costs are a net benefit. A study looked at 2015 Medicare Part D data to find that prior authorization reduced the use of prior authorized drugs by 25%, reduced Part D spending by 3%, and that the savings from prior authorization exceeded the overhead costs by a factor of 10. They concluded that we should be careful about lowering administrative spending because this spending could reduce spending overall. Unfortunately, added administrative costs are not limited to the health insurers themselves. Hospitals and other providers also bear additional administrative costs due to Medicare Advantage. A major factor for why U.S. hospitals have such high administration costs is the complexity of billing multiple insurers with different payment rates, rules, and documentation requirements. Advantage is yet more insurance plans with differing rates, rules, and documentation. Traditional is one set of rules for everyone on traditional. Additionally, Advantage burdens providers with denials, authorizations, and requirements that greatly increase the administrative costs for providers. Advantage plans can have restrictive admission criteria, prior authorization denials, limits on covered services, and deny claims. These delay care and create administrative work for providers involving paperwork, documentation, and reporting. This means healthcare facilities have to spend relatively more time with administration rather than focusing on healthcare. These problems are the worst in rural areas where there are more limited providers in the first place, and the facilities may have less staff to deal with the administration. Additionally, there may be less competition among rural insurance plans, reducing the provider's leverage in negotiations over rates. Rural healthcare facilities have trouble sustaining themselves, and the lack of competition in Advantage plans makes that harder. So, a major downside of Medicare Advantage is the increased administrative costs that burden not only the insurance companies themselves, but Advantage also greatly increases the administration costs of hospitals, doctors' offices, and other providers. Some of these costs are made up for by reducing medical use. Beneficiary affordability. Systematic reviews comparing Advantage and traditional find Advantage enrollees have more difficulty affording healthcare. Other studies find that the percentage of people with issues getting care due to cost is similar between Advantage and traditional. A 2024 study found that those who switch from traditional to Advantage were more likely to have increased out-of-pocket costs and more likely to have financial burden if they were in a vulnerable population, compared to those who stayed in traditional Medicare. This implies that how Advantage saves some people money is just by being cheaper for those who do not need expensive care, while more expensive for some of those that do. Advantage is often cheaper for a brief hospital stay, but longer hospital stays tend to be more expensive in Advantage. Denials, out-of-network needs, and home care can also make Advantage more expensive. A study looking at low-income beneficiaries found little evidence that Advantage improved access, affordability, or preventative care compared to traditional Medicare, and concluded that Advantage may not provide enough benefits to make up for the increased costs. A report by the Nebraska Rural Health Association said that Advantage plans created financial burden for rural residents to the point that people with Advantage are the largest growing segment of charity care in rural hospitals in Nebraska. Looking at beneficiaries in Advantage and traditional with the history of cancer, researchers did not find evidence that Advantage beneficiaries had better access, affordability, or acute care utilization. They did find that Advantage beneficiaries were more likely to report financial strain or having difficulty paying medical bills. A 2023 Commonwealth Fund survey found that 41% of Advantage enrollees had problems accessing care due to costs. This number for traditional was 35%. Stratifying by income did not change the result. Although less traditional Medicare enrollees had cost-related issues, this was driven by those with supplemental coverage. One study found that 15% of traditional enrollees reported having at least one cost-related problem, while 19% of people on Advantage reported this. However, of those with traditional and a supplemental, only 12% reported such a problem, while 30% of those with traditional Medicare alone reported a cost-related problem. 41% of people on traditional Medicare have Medigap plans. 90% of traditional Medicare enrollees have supplemental coverage, usually from a Medigap plan, Medicaid, or an employer. For those without Medigap or something else to pay out-of-pocket costs, a good Advantage plan may be more affordable. Whether healthcare is more affordable to someone on traditional versus Advantage will depend on one's medical situation and one's supplemental insurance. Traditional with a supplemental means healthcare costs should be covered. Traditional without a supplemental means the cost will be covered, but there is no out-of-pocket maximum, so one's personal costs can add up even if Medicare pays a majority of the bill. With Advantage, your costs may not be covered at all, so there's a chance that you will get totally screwed if the facility or procedure or doctor you need for your ailment happens to not be in-network or covered by your Advantage plan. additional benefits and lower premiums. While the government pays more for people on Advantage, and some people pay more out of pocket with Advantage, Advantage does come with benefits not included in traditional Medicare. Advantage benefits include dental, vision, a maximum out of pocket, bundling, and low premiums compared to a Medigap plan. Many Advantage enrollees pay no additional premium on top of their Part B premiums. Although these plans are often presented as zero premium plans, the Part B premium is still paid. Advantage plans can bundle Medicare Parts A, B, D, and Medigap into one plan, which is convenient. Although Advantage beneficiaries are more likely to have dental coverage, they do not use significantly more dental care. People in both Advantage and traditional are equally likely to say they have issues getting access to dental, vision, and hearing services, and low-income enrollees have the same likelihood of delaying dental care or eye exams due to cost. These poor Advantage results may be due to tight networks, unclear benefits, prior authorizations, and out-of-pocket costs. Some dental and vision plans have so limited of networks that there is no nearby dental or vision doctor who takes that insurance. It's not clear that people in Advantage use dental, hearing, or vision healthcare more than people in traditional Medicare. This may be because the Advantage coverage does not prevent a fair amount of spending due to high coinsurance and low maximums on how much the insurance company will spend. This means on expensive services, Medicare Advantage dental, hearing, and vision coverage is often more like a coupon than actual insurance. A survey showed low use of Advantage's extra benefits like vision, hearing, and dental care. In the last 12 months, 31% of Advantage enrollees had not used any of their benefits. 58% had not used dental, 59% had not used vision, 93% had not used hearing, 81% had not used the gym membership, and 54% had not used their over-the-counter medication allowance.